Welcome you all to this session on Advanced Glaucoma Management Pulse. As we all know, advanced glaucoma is a very difficult situation to deal with. These people do not have any, we cannot have any margin of error for them. They want a very acute treatment and correct treatment, and so that they can remain with the whatever vision they have got. That is very tricky situation also for the treating physician. So to deal with all this problem, we have with us eminent panel who are going to discuss about all the problems. We have Dr. J.C. Das with us, who is a very eminent personality and needs no introduction. He can guide us through all this whole session. He is an eminent glaucoma specialist with years of experience, and not only national, at the international level also, he has immense contribution to make. And we have Dr. Pratip Vyas, again, very senior consultant and medical director at the Center for Sight in the Indore. And we have Dr. Manish Singh, who is a director of the Netralayam, very fine surgeon and very eminent academician. We have Dr. Deepak Kumar Misra, who is an associate professor in the BHU RIO. And we have Dr. Rita Das, who is a senior consultant and anti-segment surgeon in the Amri Hospital, Bhubaneswar. And we have Professor P.K. Nanda, who is the HOD of ophthalmology in the High-Tech Medical College. And he has got a vast experience of more than 35 years for treating and teaching experience. So all of us will impart important clinical tips for this instruction course. I invite all the panelists on the dais so that we can have a discussion. Please come on the dais, sir. Sir. Our first speaker will be Professor Prasant Kumar Nanda. He is going to take us through the quality of life of the glaucoma patients who are at a very risk of growing blindness, and what is the quality of life of them will be discussed by Professor P.K. Nanda. Over to Professor P.K. Nanda.
Good morning. Thank you, Professor Sumita, for giving me opportunity in this instruction course with eminent personalities like J.C. Das, Pradeep, Manish, Deepak, and Rita. Really, it is a proud privilege to be here. So, coming to my topic, defining advanced glaucoma and the quality of life of patients. I don't have any financial disclosure to make. As per the glaucoma, there is no particular nomenclature in the story. But however, when the current grading system of Humphrey's automated perimetry, 30-2 or 24-2 strategy defining the severity only. So consequently, upon the HPA system, it classifies considering the mean deviation and the pattern deviation, and proximity of the defect in the fixation point. As per the Humphrey's visual field analysis, when we go through the stages 0 to 5 from ocular hypertension to the end stage of glaucoma, we define advanced glaucoma as the mean deviation when it is less than 12 decibel to 20 decibel. Along with that, at least one of the following should be there on pattern deviation plot, greater than or equal to 50%, but fewer 75% of points depressed below the 5% level, and greater than or equal to 25%, but fewer than 50% of points depressed below 1% level, or any points within central 5 degree of sensitivity of 0 decibel. This is important. Both hemifields containing a point with sensitivity of less than 15 decibel within 5 degree of fixation is important. Coming to this perimetric picture, it is obviously that when you see the picture, it sees, but actually, when you see the last one, you just miss, as it is advanced glaucoma, but actually, when the points of 0 decibel sensitivity within the central 5 degree, this case is an advanced glaucoma case. But as per the ICD classification, ICD 9 and 10 diagnostic code defines severe stage of advanced glaucoma stage and end stage of glaucoma as optic nerve abnormalities consisting with glaucoma and glaucomatous visual field abnormalities in both hemifields and or loss within 5 degree of fixation and at last one hemifield. So when we diagnose the case of advanced glaucoma and comes to quality of life, the quality of life is very, very important, because whether you treat the patient or don't treat the patient, the patient does not have any interest on that. He is interested about his quality of life, how he is the biomedical indicator does not have much to help. How he is helped, that is important. So quality of life depends mostly on the psychological effect, visual impairment, visual field restriction, contrast sensitivity reduction, and glare, and medication of surgery of glaucoma. So usually in our life, the quality of life with our normal age and the degenerative quality of life decreases. So when at the far end, we diagnose the patient to be glaucoma, there is fear of glaucoma, and with the fear of glaucoma, there is financial, medicinal cost. Along with that, the limitation of daily activities like reading, working, and ultimately the uncertainty of life with visual disability, limiting his disability, and blindness causes the person to lead a sedentary life and his quality of life is disturbed. So the most important among them is the psychological effect of diagnosis. Because the fear of blindness, when we are talking of glaucoma, the blindness simultaneously goes. Whether when you go to a doctor, they go on telling, you will be blind, and there is some technical aspect also, that anxiety, depression. It is estimated that 80% of glaucoma patients report anxiety and depression and fear of blindness. So acute emotional stress can trigger the intraocular pressure elevation glaucoma, making it a rotational cycle. So the most important is this fear of glaucoma that always hampers psychologically. Limitation of daily activities, that is also carrying out the task of walking or balancing or reading, driving and reaching or grasping or seeing a object face recognition is always difficult in case of this advanced glaucoma. Decrease in contrast sensitivity, glaucoma causes reduction in contrast sensitivity. This creates problem with night driving, including difficulty in seeing pedestrians and walking alongside with poorly lit streets. That also causes difficulty in driving. Driving in foggy conditions, that makes it very difficult. So face recognition, this is a social problem. When there is a face recognition, you suddenly cannot recognize a face of a certain person in a crowd. That you feel awkward. So when you are doing a tendential to visual field in mean deviation, there is a significant predictor of facial recognition. Patients with glaucomatous macular damage, they exhibit diminished facial recognition, which is partly mediated through diminished contrast sensitivity. So social interaction and their significant impact on the quality of life is very, very important. So this face crowding and cannot recognize a particular face in a crowd when person is little far away, mostly due to the macular damages. Tunnel vision. This creates a constricted field of vision due to the advanced glaucoma, and that is navigating crowded places is difficult. It leads to bumping into the objects, fear of fallover, or sometimes you fall over. That also creates problem. Reading disability, when we are aging and along with the advanced glaucoma sets in, the glaucoma itself causes problem. So slow reading and increased reading impairment with advanced bilateral field loss is there. Slow reading speed in glaucoma was closely related to shrinkage of visual span. Glaucoma patients take a longer time to focus on a target and identify letters. So affection of saccadic eye movements are problem. So reading is really difficult. And old age reading is sometimes the hobby. You take a lot of time in sedentary life, and reading, if problematic, is very, very difficult. Glare is one of the most important part of this advanced glaucoma. This is due to the decrease in the retinal ganglion cells layer or melanopsin, and along with that, ocular surface disorders also contribute to the glare part. Difficulty in driving. When you are habituated in life, when you are driving yourself, when the driving becomes difficult with glare, low contrast sensitivity, facing problem particularly in foggy condition, during night driving, and with entering into a tunnel from a lighted area to the dark area, it is very, very difficult, and patients with moderate to advanced glaucoma are at higher risk of unsafe driving. And when you are not allowed to driving in the night or all things, sometimes your life is little dull. So higher risk of falling, this is very important. So it is either decreased balance leading to greater likelihood of bumping into objects, fear of falling, or slower walking speed. Avoidance of activity or reduction of travel outside the home. So taking all into consideration, the patient rate their quality of life lower if visual field happens quickly. So unlikely early stages in which visual acuity and visual field of the worst eye are the main determinants of quality of life. So the main impacting eye in advanced stages seems to be the best functioning eye. So along with when you are doing advanced glaucoma, your quality of life is also decreased, and simultaneously the medications. The doctor gives a lot of medicines. In glaucoma, either you single drop, double drop, 3 drop, 4 drugs. So a lot of drugs are there. In timely you have to put, your hands will be tremoring. You can spill over the drops itself. Frequent use of the drops, and along with this, all these things, the financial cost, that also hamper. Your income has decreased, and the medications price has every day increasing day by day. Newer drugs are coming, and the price is getting up and up. So along with the financial effect on medications, how to put and how not to put, then side effects of the glaucomatous drugs. There are a lot of side effects along with the medications. It also causes problem in hampering the quality of life. So all these things, either driving, night driving, or reading, not recognizing faces, all this leads to your loss of confidence, and that is where the doctor has to step in. No patient is interested, no patient is at all interested. Yes, your IOP is fantastic. You have got a fantastic IOP, but he is not interested about hearing that fantastic IOP. He is interested, doctor, I am using so many drugs. I am financially problem. I don't drive in the night. I have some other problem with the reading, with facial recognition. So the most important here is the role of the consultant of glaucoma specialist to please give a time with the patient. Give him a little time. A counselor may be there, he can give half an hour to 1 hour, but a doctor's 5 minutes is very, very important for the patient. And if you give a good counseling, he may lead a very interesting life, or at least whatever the life is there, he will be happy with his family and children. Thank you very much. Thank you for the patient here. Thank you.
Thank you, Dr. Nanda. And an excellent talk. And Dr. Sumita is ready. But before we switch over to the other topic, 1 or 2 points I would like to add to Professor Nanda's talk. That when we talk about the vision has got different components. One is the visual acuity. That is very important. Visual acuity is just one factor, and in advanced glaucoma, the visual acuity remains till the end. It is not affected that easily. The central visual acuity. second component of vision is the field of vision. That is very grossly affected. And if the field of vision is affected in the lower half, patient will find it climbing down the stairs, he will stump to the things and will fall. So that is another biggest problem. The third component is the color perception. So color perception is affected quite early in glaucoma, and that is especially so for the advanced glaucoma. So without the color which the patient has seen for ages, so without the color perception, he finds it difficult to get used to new atmosphere, new environment. And the last thing is the contrast sensitivity, which is very, very important. Even the visual acuity is perfectly maintained. You will see that patient will always complain that I have got foggy vision, and you don't know what is happening. Why is telling foggy vision? Your vision is 6/9 and your field of vision is stable and everything is okay. And no, sir, I find it is foggy vision. That is because of the color, that is because of the contrast sensitivity reduction. And contrast sensitivity is one of the most important parameters in the visual acuity. So all these have to be taken into consideration when the patient is in front of you. In every follow-up cases, please inquire about the subjective component of the progression of the glaucoma in advanced cases. Each one is important for the patient at that stage. Thank you very much, Dr. Prasananda. Can I request Dr. Sumita?
Yes, sir. Good morning. Glaucoma, particularly advanced stage, advanced glaucoma is a very difficult situation to deal with, because not only the patient but also the caregiver, it is very difficult to maintain them. And definitely for the treating physician, it is a challenging situation. So first of all, we have to know what could have been done to avoid late presentation, which we all do not want the patient to have. So I don't have any financial disclosure to make. The magnitude of the problem is really huge. EMGT and there's CIGTS, like all these hallmark studies, they have found that almost 10 to 33% of the patients which present to our clinic are either blind in one eye or in advanced stage either in one or both eye. So this is a very huge problem. So we have to know what to do so that the patient will not reach this stage. So why a person reach this stage? It can be failure to detect glaucoma at an early stage, that is a delayed diagnosis. It can be inadequate or improper treatment, or it can be the non-compliance to the treatment on the part of the patient. So delayed diagnosis is very important. Almost 50% of the glaucoma patients in a developed country and around 90% in a developing country like ours, they remain undiagnosed. What is the cause again? It can be due to the lack of effective screening strategy. It can be due to delay at the patient level or even delay at the treating physician level. That is a misdiagnosis on the part of the treating physician. So lack of effective screening strategy. It's not cost effective or feasible for population screening for glaucoma, but we can screen the high risk patients like those who are diabetic, those who have trauma, those who are myopic, or we can do opportunity screening with the other tests like in the old days screening. But nowadays, artificial intelligence and deep learning have come, so we hope in future they can help us in doing screening for these glaucoma patients. So delayed at the patient level can be either due to infrequent eye examination or due to some misconception on the part of the patient. Glaucoma being an asymptomatic disease, the family history, if there is lack of family history or there is lack of frequent visit to the ophthalmologist, they are the major risk factors for delayed presentation. And most people usually require change of spectacles or reading glasses in their 40s. So this can be taken as an opportunity to diagnose any age-related ocular problem. But sometimes individuals without any formal training also, they sell spectacle. So this opportunity is lost. So there is certain misconception, like patients think that hazy vision is a normal aging process, so there is nothing to worry, and patients think that it is due to cataract only, so when it is mature only, they will get it operated. That's not the case always, and patients sometimes also think that I am not having any symptoms, so why should I test for glaucoma? So these conceptions have to be clear from the mind of the population so that we can have some early cases. Then delayed diagnosis can be due to the misdiagnosis on the part of the treating physician. It can be due to over-reliance on the single IOP measurement. We see a lot of ophthalmologists, they see that the pressure is low. It's not 21, so it's not glaucoma. But 21 is not the magical number. It is only a statistical average. Moreover, IOP alone has its limitations, and it depends upon the central corneal thickness. And there are also IOP fluctuations. So we have to keep those things in mind before taking only IOP as a reading. Moreover, threshold for IOP-induced damage, it varies with the patients even. So that same IOP amount may be sufficient for someone, may not be sufficient for other. And the in glaucoma diagnosis, the cornerstone of diagnosis is the studying the optic disc. So many causes of glaucoma are being missed just because optic disc was not looked at. The glaucoma optic neuropathic evaluation study, which assesses the reading ability of the fundus picture, they show that 20%, almost 20%, that is 1 in every 5 disc photographs were underestimated for glaucoma likelihood. This is not very encouraging scenario. So what are the key factors that led to their underestimation? It can be due to underestimating the vertical curve disc ratio, or it can be missing the retinal nerve fiber layer defect, disc hemorrhage, and neuroretinal rim loss. Disc hemorrhage is a very important finding in glaucoma or in glaucoma suspect, because that indicates that the patient's glaucoma is progressing and we should augment our treatment. And vertical CD ratio in inferior and any rim loss, and it be superior and inferior, they are indication that the actions of the retinal nerve fiber cells are damaging. So we have to think that into account also. And RNFL defect is one of the earliest signs of glaucoma that one should never miss. The missing angle closure component is very important in our country, because PSEG is common in Asian countries, and it carries 3-fold increased risk of severe bilateral visual improvement in comparison to primary open-angle glaucoma. But the common misconception is that angle closure glaucoma presents only as an acute attack. But subacute angle closure glaucoma also can lead to chronic angle closure glaucoma, causing a lot of visual disability. Only gonioscopy and timely laser iridotomy will halt the disease process. In our practice, we see a lot of glaucoma patients who are diagnosed to have primary open-angle glaucoma, but in actual fact, they are primary angle closure glaucoma. They are going on putting increased number of anti-glaucoma medication, but land up in advanced stage of the disease. Their vision could have been saved by just only a timely gonioscopy and timely peripheral iridotomy. So this has to be taken into account also. Many other systemic conditions and medications like diabetes, hypertension, thyroid eye disease, and steroids, they also cause glaucoma. And multiple medications for other conditions, they can also precipitate an acute angle closure glaucoma, like MAO inhibitor, tricyclic antidepressant, antihistaminic, and mediatrics. This also have to be kept in mind. So overlooking the signs of secondary glaucoma also will land us in having the patient in an advanced stage, because pseudoexfoliation is very common in our part of the country, and particularly it is important because its conversion to open glaucoma, PXG, is almost 50%, and the glaucoma due to pseudoexfoliation is very notorious, that it progresses very rapidly, and it usually does not respond to medical treatment that well. And moreover also uveitis, there are dual change we should see. Can be the glaucoma can be due to the medication itself, like steroids, or it can be due to the disease process. And sometimes if we miss the pupillary area neovascularization, we will land up in very advanced stage of neovascular glaucoma, which is really not responding to treatment. So we have to look at, before the dilating the pupil, particularly in diabetic patient, the small amount of fine blood vessels in the pupillary area. And we have to take the history of steroid indication also, and trauma also have to be evaluated. So there can be underestimate the severity of the disease damage, because target IOP is dependent on the baseline damage, and underestimating severity will lead to setting a higher target pressure, hence less aggressive treatment and disease progression. So we have to stage the disease properly, because if we see any field defect, then the glaucoma is no more in the very early stage, it is already in the advanced stage. And seeing a notch or seeing a disc hemorrhage will alert us that we have to augment our treatment. And IOP reduction is not sufficient, then also patient will lead in the advanced glaucoma stage, and we have to take care of the IOP peaks. 24 hours IOP monitoring is best, but it is routinely not feasible, and we can perform DBT during the office hour. And water drinking test is also another very good test which we can do that will show us the IOP peak. So for an asymptomatic disease like glaucoma, ensuring compliance is very much important, because without compliance, the disease progression, the disease will progress to its advanced stage and we cannot do anything about it. So late presentation of glaucoma is an important risk factor for glaucoma blindness, but blindness is not a certainty in patients with advanced glaucoma. So we have to deal with it correctly so that patient will retain whatever amount of vision he is left with. To discuss with that, we have the next speakers. My next speaker is Dr. Pratip Bass, who is going to tell us how monitoring is important, because it is different from the routine cases. Over to Dr. Manes.
Thank you, Professor. Thank you, Professor Sumita. You have covered practically all the aspects why we face the problem of late diagnosis of such patients. They come very late. Presentation is very, very late presentation. So I will have some question to Dr. Pratip. What do you think, what is the commonest cause in our setup that the patient present to us so late?
See, the biggest problem in our population is that the patients are not aware of the condition. So we have to educate the mass population about the glaucoma, and how we can do only by organizing the camps at the various remote places. If you detect glaucoma early, then obviously you can prevent the blindness caused by the glaucoma. Remember one thing, that primary open-angle glaucoma and normal tension glaucoma, they are not so notorious conditions. They progresses, but they progresses slowly. The most notorious for causing the blindness is angle closure disease and secondary glaucomas. Secondary glaucomas are pretty common in our country, particularly the pseudoexfoliation, pigmentary, steroid-induced. Steroid is used right and left, particularly in a pediatric patient for vernal keratoconjunctivitis. So remember one thing, that there should not be steroid abuse in any condition. If there is not a steroid abuse, then at least in pediatric patient, the blindness caused by the glaucoma can be prevented for a very, very large extent. But for early detection, you have to reach to the population, whosoever are suspect, bring them to the base hospital, do the detailed investigation. Don't ever forget to put the gonioscope in each and every patient who are suspected to have glaucoma. In spite of very deep anterior chamber, they may have an angle closure element. In these patients, if you do the laser peripheral iridotomy, then you may save these eyes from going into blindness. Thank you.
Now I request Dr. Pratip Bass on challenges in monitoring advanced glaucoma in patients. Please.
Good morning, friends. Thanks, Dr. Sumita, for giving me this opportunity. I would be talking on the challenges in monitoring advanced glaucoma. All of us are fully aware that the glaucoma is divided into mild, moderate, and advanced glaucoma. Glaucoma is a chronic progressive disease, and it has to be monitored very meticulously. If you do not monitor the disease meticulously, then it is likely to progress and may cause blindness. Monitoring the mild, moderate glaucoma is not very difficult. Monitoring advanced glaucoma is not also very difficult, but monitoring very advanced glaucoma is very difficult. So in this talk, I am going to cover how to monitor very advanced glaucoma cases in your practice. Mind it, because glaucoma is a silent killer of vision, very often you get the patient who have very advanced glaucoma. It is also called as a late or end stage glaucoma. So this is the classical definition of glaucoma. You have a classical glaucomatous optic neuropathy with correlating visual field changes. No one would have any problem in monitoring these cases if there is a good compliance, if the patient comes to you for a regular follow-up. Obviously, you can monitor, you can pick up the progression at any stage, and you can modify your treatment strategy, and you can prevent the patient from landing up into irreversible blindness. But the real challenge is to monitor the end stage or a very advanced glaucoma. The reason is that what modalities you have to monitor the glaucoma. Glaucoma can be monitored by doing the stereoscopic disc photograph. In very advanced stage, where there is no neuroretinal rim, you cannot observe the progression just by taking the stereoscopic photograph. The second equipment is OCT or any imaging device. Other imaging devices are not available, it's only the OCT. OCT has its floor effect, we will discuss subsequently. So you cannot monitor a very advanced glaucoma based on the OCT. So you are left only with your gold standard perimetry, but there are also n number of challenges in monitoring these glaucomas even on the perimetry. Why? That you would be knowing. This glaucoma is a very early glaucoma, very easy to monitor, and I'm sure that if the compliance is good, then this patient will never ever end up in blindness. But this glaucoma, you have a very small breathing space, and whatsoever he has got, whatsoever is remains, you have to preserve it. Then only patient would be having a functional vision, and he will not be dependent on any of his family member for his routine day-to-day activities like having a food or taking bath or going to lavatory and so on and so forth. Otherwise, 24 hours attendance are required. So this is one of the case. You can see that there is almost a total cupping, and you can see that very, very small narrow island of vision is left. Dr. Das was discussing about that. Some of these patients are very intelligent, and through this very narrow island of vision, they have a reasonably good vision. Remember that that is just a vision. The quality of vision is poor, very poor, but still if they are able to focus the television or if they are able to focus any object, they would be able to do the activity, and once they move the face, they miss the object and it becomes very difficult. So monitoring these patients is very difficult, but we have to save the vision somehow. If you do the perimetry on a standard 24 days 2 or 30 days 2 program, you do not get any information out of it, because even the perimetry has a floor effect, where only couple of decibel are left, then what you would get or what you would interpret it out of it? Nothing. Same thing is true with the OCT. Because of the glial tissue, because of the blood vessels, the floor effect in the OCT comes at pretty early stage. And below 40 micron, you cannot pick up any defect, and you have to leave it like that. And perimetry is not at all useful in all those patients who have the RNFL thickness less than 40 micron. So the perimetry is useless. So what to do? If you have these kind of a small field, you have to find some strategy. And yes, all the perimeters are equipped with various strategies. The one is that you can use the stimulus size 5, that's a bigger object, And if the bigger object is there, if the patient has a poor vision, then also they would be able to pick up. But there is a problem with the strategy 5. You cannot do the progression analysis. But you are equipped with another strategies, that is 10-2. If you do the 10-2, then obviously, yes, you would be able to pick up very small defect also, and that defect can be monitored for progression as well over a period of time. The difference between 24 days and 10-2 is that there is a resolution of 6 minutes if you have selected a strategy of 24 days 2. But there is a resolution of 2 minutes if you have selected the strategy of 10-2. There is a huge difference. But 24 days 2C is not useful in that because they just have 10 additional random points, so they do not increase the resolution of the test you get. The total number of points you test is 68 as compared to the 54 points in 24 days 2. And see the difference. It's a very small field, and when you do the 10 days 2, you get a much better information to interpret. That is the important. Here you test only 12 points where 40% of the ganglion cell lies. And here you test 58 points where 40% ganglion cell lies. So obviously testing 58 points in the central 10-2 is more important than testing just 12 points. And remember that, the spot size 3, almost 230 ganglion cells function can be assessed by one single point in the central area. While in the peripheral area, it's only the 10 ganglion cells are present for stimulus size 3. So obviously the central area is more important for all advanced glaucoma. And any single decibel deviation in 3 consecutive points is significant. And even if you have a very advanced case, then mean deviation, if deviated by 1 decibel, then also consider as a significant. And you can monitor these patients for a smallest progression, and you can preserve that vision that patient has got. So in summary, the visual field assessment is very critical. But remember, if you have a patient of end-stage glaucoma, then the 10-2 strategy is the best strategy. You can monitor the glaucoma and you can pick up the progression little early, and probably you would be able to save a useful vision the patient has got. Thank you very much for your patience hearing.
Thanks, Dr. Vyas, for very elaborate topic and deciding the topic. Then our next speaker is Dr. Rita Das from Amri Hospital, who is going to talk about the medical management in case of very severe advanced glaucoma. Over to Dr. Rita.
Good morning, everybody. Coming to my topic, recent medical management in advanced glaucoma. I don't have any financial disclosure. In any glaucoma, our main goal is to preserve whatever visual function is there, to keep it, and to maintain the quality of life of the patient. And in advanced glaucoma particularly, this is very important because already the damage is very much. And coming to the recent medical management, lot of newer anti-glaucoma drugs are available, like ROCK inhibitors, netarasudil, latanoprost, prostinbunod, and the combination therapy like latanoprost and netarasudil. That doesn't mean these recent medical drugs available are the first choice of treatment in case of advanced glaucoma. That I want to emphasize. These are the newer drugs available, but these are not the first choice of drug. And in a glaucoma particularly, when there is rapid rate of progression, as in E, or the patient is at a young age. So our treatment modality is aggressive and we want a very low target intraocular pressure, either in lower teens or single digit in higher number. So coming to the consideration of first choice of treatment, where the likelihood of symptomatic vision loss is more, we take into account lot of things when we are considering our medical therapy. What is the advanced initial damage, and what is the rate of progression, and what is the life expectancy of the patient, and additional risk factors like any cardiovascular risk factors, migraine, TIA, and use of steroids or anything like that, or any adverse consequence to intervention. Suppose the patient cannot go for surgery, split fixation is there, and chance of wipeout is more, so we go for medical management. So all these things are to be considered while giving the first choice of treatment. And after considering all these things for and deciding for medical therapy, we set the target IOP according to the patient's status of the disease. And while setting the target intraocular pressure, what I want to emphasize, both the eyes should be considered, because the disease in both the eyes are different. They are not same. And the target intraocular pressure is decided according to the damage in each eye. So both the eyes are considered while deciding the target intraocular pressure. And the patient preference should always be considered while deciding the target intraocular pressure. Coming to the first choice of treatment, how to go about it in a systematic way. First of all, we should see the systemic condition. Any prescription we are giving, we are writing first whether there is any drug allergy or not. So exclude any drug allergy first before deciding for the treatment option. Then one has to ask for any specific disease, systemic disease like asthma or arrhythmia, because we cannot give so many drugs there. And note any concomitant medication he is taking, because if the patient is taking systemic beta blocker, he cannot take the topical beta blocker, it will not be that effective. So systemic condition to be taken into account, and along with the ocular characteristic like ocular diseases and concomitant eye diseases. In the ocular diseases, if the patient has any ocular surface eye disorder, the preservative-free medication should be considered, and if there is a concomitant eye disease, that should be considered before deciding the first line of therapy. So, because we cannot reverse back, we cannot go back, so proper history taking and proper examination and proper evaluation of the patient is important before starting the medical therapy. And in the first line of therapy, particularly, usually we consider prostaglandin analogs or prostamides, beta blockers, alpha-2 agonists, and carbonic anhydrase inhibitors. And when choosing the therapy, first line of therapy, from either PG analog, beta blocker, or any of these things, or other modalities also, if it is well tolerated and effective on the intraocular pressure and our target intraocular pressure is achieved, periodic evaluation should be done. And like visual field, optic disc, and intraocular pressure monitoring should be done. If it's stable, the follow-up should be done, and in an advanced glaucoma, it should be in a 3 to 4 months interval, because short-term follow-up is required. And if the target IOP is not achieved, the second drug usually added, or if it is not, the first drug is not well tolerated or not effective, the switch the monotherapy or consider other modalities of therapy like laser or surgery without any ego. And if the target IOP is reached, but it's not to our level what we want, then the second drug is added and the target IOP is again monitored. If the target IOP is not reached after adding the second drug, substitute the second drug and verify the efficacy and tolerability. And also you can consider, if you are not comfortable with the second drug efficacy and tolerability, you can consider other therapeutic options like surgery and laser. And long-term, short-term fluctuations while giving any drug in advanced glaucoma is very much important. So that should be always kept in mind. because fluctuation is the very important risk factor for progression. So coming to the target intraocular pressure, there are a lot of definitions for target intraocular pressure. This one is from World Glaucoma Association. Target intraocular pressure is an estimate of the mean intraocular pressure at which the risk of decreased vision-related quality of life due to glaucoma exceeds the risk of treatment. If you don't treat, the risk is more than the risk of treatment. So you have to treat. There is no alternative point. So in advanced glaucoma, it appears to need to decrease the intraocular pressure to less than 14 millimeter mercury, and preferably it should be below 12 millimeter of mercury with minimal fluctuation over time. And for normal tension glaucoma, a fall in intraocular pressure below 30% from baseline has been shown to be significantly reducing progression. And a study from Sehota et al. Has shown when the intraocular pressure is below 12 millimeter of mercury, the progression rate is only 2.3%. And coming to the patient approach, actually it's an advanced disease, so quality of life, everybody has told it's very much affected. So it should be treated in a holistic approach, that is a bio-psycho-socio-spiritual profile of each patient should be taken into account, and the patient should be treated very carefully, and it should be a team effort. And patient care personality, their relatives, they should be well informed and they should be taken into the team, and the patient should be treated in a very careful manner so that the quality of life would be should not be impaired. So patient characteristic like his clinical picture, systemic condition like any systemic or ocular condition is there or not, particularly adherence of the patient, which is very important, and quality of the life should be taken into account when patient characteristic is considered for first choice of treatment. And along with the drug properties, which is also important, mechanism of action, because when we are combining two drugs, there should not be same mechanism of action, because the effect will not be that much of additive. And efficacy of target IOP and unpreserved drugs should be considered, along with the cost, which is not the least important factor, because they are elderly patients. So to conclude my talk, monotherapy is the first choice when initiating therapy. Baseline IOP should be considered while evaluating therapy. Fixed combination are not first-line medication to be considered where individual intraocular pressure targets with monotherapy fails. Prescribing more than 2 bottles of intraocular pressure lowering drops to be avoided as it may affect compliance. In case of ocular surface disorder, preservative-free combination to be considered. Generic drops can differ from brand drops and should be monitored more closely after switching to generic drops. And during pregnancy, in young patients, potential risk of continuing anti-glaucoma medication to the fetus to be balanced against the vision loss in mother. Thank you for your kind attention.
Thank you. Thank you very much, Dr. Rita. In a very short time, you have practically covered all the aspects of medical management. I'll just tell you some of the carry-home messages. But in advanced glaucoma cases, don't give a medication which will cause low blood pressure. So that will worsen the situation. Second, the monitoring of the treatment of hypertension, which most of these patients suffer from, have to be really, really carefully done, because a nocturnal dip with antihypertensive medication is likely to worsen the situation. Don't use a medication, glaucoma medication, locally, which is likely to damage the macula, CME, chronic macular edema. That will take away the central vision, for which the glaucoma is totally, the advanced glaucoma patient is totally dependent on. So he's already lost the peripheral vision, and you are using the medication without realizing that you are also damaging the central vision. You are causing more harm than doing any good to the patient. Now, you have to choose a medication which has multiple actions. It has got, increasing outflow, decreasing production, increasing vascularity or vascular supply, or neuroprotective action. The Rho kinase inhibitors is meant for all these purposes, and it is likely that this medicine with a modified form, I don't think the presently available Rho kinase inhibitors, which are known to cause the low blood pressure, it will increase the scleral, they decrease the scleral resistance, episcleral venous pressure, and it also provides the nutrition to the ganglion cells, and protects the neural cells, also increases the vascular supply in the optic nerve head. But we do not know whether this is really doing the job, and we may have to use it for longer time and expect a newer medicine to come up to serve this expectation of ours. Yeah, Dr. Sumita.
Next speaker is Dr. Deepak Kumar Misra. He is going to talk about the role of lasers in advanced glaucoma.
It's okay. Thank you. Thank you, ma'am, for including me in your IC. And good morning and warm welcome to all of you. There is no financial interest. We all discuss whatever the modalities are there and why surgical, why medical, and why lasers. These are the three things which is important in the management of the glaucoma. And since you have seen a huge market, just ma'am told us that how these markets affects the economy of the patient and everything. For that, we can have something in our treatment box, that is the lasers. Lasers have many uses and few indications are helpful for the community to reduce the economic burdens, for increase of the compliance if patient is coming from remote and not coming to you every time. And important one is, it is actually an adjuvant or an alternative therapy. It is not anywhere indicated as a first line therapy. It may be combined with drugs or surgeries or some in cases of prophylactic. So I'm skipping these slides about the laser, and there are the various sources of lasers and the wavelength you can find out. They can be solid or liquid lasers and have different wavelengths for that. And these are the three possible mechanisms by which a laser can act. This is not, we can use each and everywhere. But here is in advanced glaucoma, we have 3-4 different options. Most important is where is a chances of you suspect as a clinician for the internal block, then which type of laser you used, and when there is a chances of outflow obstruction, then which type of lasers are used. We mainly concentrate on these two different internal and outflow obstruction, and there is some also miscellaneous uses, not for here, but some in cases of advanced glaucoma, if there is chances of removing suture or anything, you can also use. But we concentrate only on these two aspects. Now the laser PI. This can be done with the argon laser, and these are the various conditions in which we can use it in acute angle closure glaucoma or the chronic. It is, we can say it is almost the most common type of indications for using lasers in the glaucoma. And the basic mechanism behind this is it requires energy, that it works on the principles of the photodisruption. So whatever we can give, it just coagulate the tissue and make an alternative pathway for the drainage. We can do it by argon laser or Nd:Arg laser. I just put this slide here for someone who is practicing, or for the residents. They have asked mostly these questions: what are the different parameters used in the argon laser and the Nd:Arg laser? Because in the laser, parameters are of much more important. Then before doing, you must know how your machine is behave and what parameters to be set to make it more and more effective and comfortable. So, and these are the common problems or the error that occur during the LPI. One of the common is that iridotomy is not patent, and what our teacher says, our book says, that whenever you have done the laser PI, in the first of all, you can see a sudden gush of aqueous coming from it. There is change in the anterior angle chamber, and most important if in cases of advanced glaucoma, even you can, if do the gonioscopy before and after laser, you can find out what are the changes and how these angles behave just after putting 3 or 4 slots on the laser. Now, the laser for the advanced open angle glaucoma option is the ALT, and ALT works on slightly different mechanism that it helps in the stretching of the trabecular meshwork and clean the debris from the network too. And this is, SLT is something said to be a much more advanced and better because it works and useful in cases of failed ALT or whatever. Just Professor Vyasar said that most of the vision threatening causes includes the secondary glaucoma like pigmentary or the pseudo exfoliation, and these SLT is supposed to be better for it. Here you can see in the SLT we target only the melanin component of the trabecular meshwork, or which is the pigmented one, and this have something different mechanism. It works on the basically the release of these cytokinins, and these cytokinins works on the endothelial layers and the trabecular meshwork. Another one is MLT, that is the micropulse laser trabeculectomy. Here you have seen, and this is a slide which shows very important to show all the differences between ALT, SLT and MLT. But what we can find out advantage of SLT and MLT is you can theoretically repeat it and even the practically repeat it, but for ALT repetition is not possible. And second one is the thermal damage. The thermal damage, or this is only SLT is a selective destruction of pigmentation, and it is not the selective. It is a whole soul burning of whole thermal. And in MDLT, thermal defect is very less. I am seeing you the electron microscopic picture of the trabecular meshwork. Just after ALT, you have seen how much structurally it disturbed, and with the micropulse laser technique, how the anatomy is also the maintained during it. Cyclodestructive procedures just leads to lot of hypotony and different thing, but for a cases or places where these facilities are not available and there is some emergency or something you can do, or better, we request you to not do it so commonly and refer the patient to the available options where is the available. And laser sclerotomy can be done for some cases if it is available in a good center, and usually the failed cases and multiple surgeries, everything. And this is the laser setting for the all types of glaucoma procedure. If anyone is wish to do, at least remember 3 things: what will be the spot size, what is the duration, and what is the power of your laser. These 3 things I have tabulated in all the things for NDR, PI, or the photo disruption, or the suture diagnosis. Anything you want to do with laser, at least have the snapshot of this slide to save or put it onto your table so that your fellows and residents are much more comfortable, and never for just like a checklist we put it every time we give intravitreal injection, but again in most of the OTs we put it to have some intravitreal list. Similarly, this is the list for the lasers. Whatever the setting is important, and you have to know all the settings in the laser. With this, I can conclude that lasers, as ma'am said, is also a very important in the management of the advanced glaucoma, and useful in cases of when we can add on for the medical or the surgical treatment too. And with this note, I would like to thank you. Thank you, sir.
Thank you, Dr. Mishra, for excellent talk on laser. A few comments on the laser is that ALT, SLT or MLT are the treatment modalities in the advanced glaucoma, specifically advanced glaucoma has a very limited role. And especially these type of lasers are not very effective in Indian eyes, but even then one can do it on very, very certain specific situations temporarily, because the effect remains only for 2 to 3 months to 4 months. Say for example, a clinically young lady has got advanced glaucoma, and you cannot give any medication for the child, the baby will be affected. So if you are not prescribing any medication, what is alternative? So you can resort to SLT or even ALT, which still not performer in Indian situation, or even MLT temporarily for such patients. Second is patient is not agreeing for this surgery and your target pressure is not achieved. Then you think of doing something so that you buy little time, maybe few months, till the patient and the relatives decide for these surgeries. If you have got the best option of any surgery which is more predictable with endo-laser cyclophotocoagulation. So if you can, you have that facilities, or you refer the patient to those facilities where the surgeon, which is a little more trained and maybe in association with the retina man, he can do endo-laser cyclophotocoagulation. That will be more predictable, and that will be most ideal where the target pressure is not achieved with the medication and the patient is reluctant for the surgeries, or in spite of the surgery, the progression is still there, whatever may be the reason. So in such situations, one can go for endo-laser cyclophotocoagulation, which is more predictably, you see the ciliary body processes and you burn them and see that they are destroyed and has shrunken. So that will be a better choice. With this, I will certainly request the next speaker.
Okay. Our next speaker is Dr. Manes, who is going to take us through the different steps of the surgeries in advanced glaucoma. It's definitely a tricky situation, because he's going to give us the tips how to avoid the complications. Over to Dr. Manes.
Thank you, Madam. Respected members on the dais, and thank you so much for having me part of this program. So I've been asked to discuss about surgical challenges and tips to avoid complication in advanced glaucoma. So next 10 minutes, I'll give you a very brief overview of what are the most common challenges which we face from a perspective of advanced glaucoma, although complications are similar in other glaucomas also, and some important tips. From surgery point of view, trabeculectomy is still the best surgical option, because we know trabeculectomy can give you IOP in single digits and low teens. Direct cyclophotocoagulation, we know, has a high risk of vision loss, and MIGS and non-penetrating glaucoma surgery cannot achieve the target IOP which you want in advanced glaucoma, so they are not a good option for advanced glaucomas. Glaucoma shunt, again, are very, very good option, especially in failed TRAVs, but certain types of secondary glaucomas like neovascular glaucoma, uveitic glaucoma, post-retinal surgery, you can also use them as the primary option. If you're dealing with a case of primary angle closure glaucoma with very advanced cupping, and you have early cataract with a shallow chamber, maybe removing the cataract will also help you to get more space and will definitely reduce your complications like malignant glaucoma. The most dreaded complication in advanced glaucoma is macular wipeout, but in reality it is very, very rarely reported. Basically, wipeout means a severe vision loss after surgery without any obvious cause. There have been multiple studies which have tried to find what could be the possibility of why there is no obvious cause, and they have found it could be because of retrobulbar anesthesia or even a large amount of peribulbar anesthesia causing pressure of the optic nerve. So whenever you are doing a surgery, avoid going too close to the optic nerve, avoid adrenaline. Sometimes a post-operative IOP spike or a hypotony can lead to some progression of glaucoma, can cause some macular edema, and that can lead to progression of the disease in already compromised eyes. So some tips for these patients: one, you have to document it, as I think Patipya sir was mentioning the importance of 10-2 program. 10-2 program or a macular program, you should note this split fixation. Also, if it's rare complication, but still you should discuss with the patient. Sometimes maybe because of choroidal or maybe because of hypema or unexplained inflammation, you have a decrease of vision. But at least the patient will tell you, okay, this particular thing was mentioned to me that the vision may go down after surgery. If you're comfortable with topical or subtenant anesthesia, that is a very good option. If you're giving a peribulbar or retrobulbar, stay away from optic nerve. Don't use lot of excessive amount of anesthesis. Avoid adrenaline. No compression, no balloon should be done because these are already compromised nerves. Post-operative IOP monitoring is very important on day 1, day 2. Sometimes when we have checked pressure, we get a pressure of 40, 30 on day 1. These 40, 30 pressure for 4-5 days is good enough to finish whatever little nerve is left in these patients. So in post-operative period or day 1, day 2, if you see high pressure, massaging can be a problem because that can start a leak. In these cases, a short course of oral Diamox or acetazolamide can be useful to prevent any harm to the optic nerve. Another problem in advanced glaucoma is a low threshold for complication. These are already compromised nerve. A little bit of choroidals, macular edema, hyphema, inflammation can lead to decrease in vision. But the problem is trabeculotomy is an unpredictable surgery, and even in the best of the best hand, you cannot totally avoid complication. So for this, again, it's very important you have to be really meticulous with your surgery. All the steps have to be very careful. Like cases like these where you see a lot of these patients with advanced glaucoma, patients are having drug allergy, ocular surface disease. These cases, you first treat the ocular surface disease, treat the drug allergy, remove the drug, give a course of oral Diamox. You can use mannitol to decrease the pressure. These things are important because that will enhance the overall success of your surgery. We routinely use low-dose fluorometholone for all our TRAP patients because most of the patients now are 3 on 4 medication and they do have conjunctival inflammation. If patients who are one-eyed, you can operate them early morning, remove the patch same day and see them in the evening. Then you can check the pressure also. Plus, it gives a psychological advantage to the patient because, one-eyed patient, when you patch them for 24 hours, it's very depressing and stressful for this patient. Also, a lot of time, patients are referred to you for surgery and there is a gross progression. Before you jump for surgery, reevaluate the patient properly. Like this particular patient was planned for trabeculotomy because there was a gross progression in the period of just 4 to 5 months. But this was an unexplained progression. When we did a neuroimaging, we found patient actually had a sphenoidal carcinoma. So when you are having such unexplained progression, you are planning for surgery, have a proper evaluation of the patient because once you have operated, somehow the onus of all the problem now comes on you. Intraoperatively, we use mitomycin routinely for all advanced glaucoma, for all glaucomas in fact, because again we need low target intraocular pressure. Pre-placed suture can be very important because it saves a lot of time in that crucial juncture. Use releasable sutures and go for slow decompression, especially in patients with high pressure. This is a patient whom you can see there is already a post-VR surgery done. We are doing a trap. Pre-op pressure was 40. We gave mannitol, pressure came down to 30. But once you open the eye, the pressure is 0. That time, it's the time when the blood vessels dilate, when you have this choroidal, suprachoroidal. If you have a pre-placed suture, it definitely saves a lot of time at that crucial juncture. In releasable suture, again, whenever you're giving releasable suture, you can have an option of going for a tight closure. So definitely you will have less chances of shallow chamber and post-operative hypotony. And later on, as per the need after 3 days, 7 days, 2 weeks, you can always release the suture and increase the flow. Intraoperative atropine, a drop or a subconjunctival can be very good in patients with shallow chambers and angle closure glaucoma to reduce your chances of malignant glaucoma. Post-operatively, again, have close follow-up, especially for advanced glaucoma. Try to see any unexplained high pressure and manage them. Whenever there is a complication, discuss with the patient. If you discuss the complication, it's much easier to manage because if you're hiding, then you have to becomes more difficult to manage complication. In any patient with too much of bleb inflammation, you should use 5FU injection. This is a video of releasable suture. You can see the bleb is flat. It's been around 10 days after surgery. You can just pull the suture. Mostly after pulling the suture, you will see the bleb will start to form. And if it's not forming, a little bit of massage beyond the bleb is good enough to form the bleb. Yeah. Another issue we have seen with glaucoma patients is unrealistic expectation, especially patients who have been on treatment. Once they go for surgery, they feel probably the glaucoma will get cured, they will not have any progression. In advanced glaucoma, again, very important, you sit down with the patient, you discuss all the possible complications to avoid any unnecessary disappointment. I'll suggest you to please have a proper written consent in the language of the patient. Give it to the patient. Tell them, please read it, and you ask whatever question you want to ask. That extra 10-15 minutes of chair time will save a lot of time in post-operative period. Trabeculotomy is a very interesting surgery where the vision can go down but can never improve. So this extra time will definitely help you. What we always tell our patient is, yes, surgery has a risk of say 2 to 5% the vision may go down. But if you don't go for surgery, you can always be 100% sure that over a few years, definitely your vision is going to decrease. Also very important, don't try to become a Robin Hood. Don't try to take all the decisions on behalf of the patient. You discuss with the patient, tell them the options we have, but the final decision should always be patient's. Don't force the patient for surgery. If the patient is not convinced, don't force the patient for surgery. And the last point, I think, which Sumita madam was also highlighting, poor compliance is very commonly seen in patients with advanced glaucoma. This is the reason why they are detected late. Sometimes they're not regular with their medication. They don't come for regular follow-up. But after surgery, also compliance is important. They have to come for regular IP checkup. They have to come for pressures. Just a surgery alone doesn't mean they don't need to be under follow-up. And that point also needs to be highlighted to these patients. To conclude, I say advanced glaucoma definitely has a high risk of blindness. Treatment is challenging, but don't delay the surgery for too long. Surgery is again the best option for patients where they are not controlled medically or with laser. And you have to have a team approach. It's a good idea if you have a corneal surgeon and a retinal surgeon with you so that you can work as a team and give the best possible treatment for your patients. Thank you so much.
Thank you, Dr. Manish, for the excellent talk. And just again, 1-2 comments. In advanced glaucoma cases, you are planning for the surgery, see that there is no intraocular increased spike post-operative. One point very, very important. Even if it is temporary for 1-2 days, enough to knock off whatever little vision he has. So many people do the surgery in the morning, keep the patient in the hospital. After 2-3 hours, they check it whether the pressure is high, and once they're satisfied, they let the patient go home. More important than the high pressure is the low pressure. At any point of time during surgery, in immediate postoperative or late postoperative, intraocular pressure should not be low. I will tell you why this is necessary. Once the intraocular pressure is low to the extent of hypertony, not low means we need the intraocular pressure to be low in the range of 8, 9, 10, but it should never be less than 6, which we define as the hypertony. The reason being, once you achieve that pressure of the hypertony, there will be certain changes in the optic nerve head, which will worsen the visual prognosis for the patient. First thing happens is the lamina cribrosa, which is already thinned out and is already damaged, already flexible. Once the intraocular pressure is low, it squeezes the rest of the axons passing through the optic nerve head, it strangulates them at the optic nerve head, and the transaction between the optic nerve head from the retina to the brain is gone, the exoplasmic transport is blocked, and that will lead to, even if it is temporary for few hours, enough to knock out the vision. The second possible mechanism, that may be microaneurysms or micro or say blocks or for coagulations in the optic nerve head once the intraocular pressure is very low. And because the multiple clots in the optic nerve head, the vision goes. Third possibility is that is difference between the cerebrospinal fluid and intraocular fluid, intraocular pressure. So that difference will reverse the flow and will again affect the vision. So there are 3 possible very important reasons should be kept in mind to see that there is no hypotony even during the time during the surgery, because even the few seconds of flat antechamber and the atmospheric pressure and intraocular pressure is 0, the choroid expands immediately, instantaneous. And the choroidal volume is 480 microliters, antechamber is 150 microliters. So once it is collapsed, even the 20% of expansion which occurs instantaneously in the choroid is enough to cause a very shallow or the flat antechamber, enough to cascade the formation of the choroidal effusion or even choroidal hemorrhage, leading to still further lowering or high pressure. So important thing is keep in mind that hypotony should not occur in any point of time during surgery. Thank you, Dr. Manish, for the excellent talk.
Thanks, Dr. Das. We now have one key note address by Dr. Samas Mohammad Norman, who has come all the way from Bangladesh to give us key talk. Then over to Dr. Norman.
Then we won't have any time.
Yeah.
Okay, doesn't matter.
After that, if we have some time, we can take some questions from the audience. Please keep that ready.
Respected chairman of this session, respected speakers, my dear, excuse me, my dear experienced audiences, good morning. I'm Dr. Shams Mohammed Numan. I'm going to talk on glaucoma drainage devices, my experience. I'm the Associate Professor, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. I don't have any financial disclosure during this presentation. Refractory glaucoma is a challenge. Management with glaucoma drainage device implant is another challenge. Okay, then we can take those challenges. What is the problem doing and taking those challenges? One is the device may not be available. Those are expensive. Expertise is necessary. Lack of interest because the advanced glaucoma surgery is non-rewarding. Lot of complications can be occurred. Counseling is a very important part doing such type of glaucoma drainage device implant surgery because patient may not agree to perform the surgery. Still it is possible with 3C. One is we have to think, we have to care the patient, we must be committed, and we have to make ourselves confident doing this surgery. What are the refractory glaucoma? We know, and in this Indian subcontinents, the neovascular glaucoma is the most commonest cause of refractory glaucoma, failed trap, axonal Rieger's anomaly, iridocorneal endothelial syndrome, aphakia, pseudophakia, uveitic glaucoma, and congenital glaucoma. Different tubes and glaucoma drainage devices, you know, one is non-valved and one is valved. The commonest valved implant is Ahmed glaucoma valve implantation, and non-valved is in the European and in the Western region, the Barvelt implant, and in this subcontinent, Adi implant. The non-valved implant, there are a lot of advantages. The disadvantage is only the surface area is more. But in the valved implant, the surface area is less, and it is quite effective and easy to do this surgery. The comparison between the Barvelt implant and Ahmed implant, the success rate is a little higher in the Barvelt. Hypotony is more common in Barvelt. Barvelt is the Western variety of actually Adi implant. The postoperative anti-glaucoma needed less in the Barvelt, but immediate intraocular pressure control is more in the Ahmed tube. This is one surgery which was done in a childhood refractory glaucoma. It is a Ahmed valve implantation. The most important thing, we have to take a very good exposed area to create a pocket to implanting the Ahmed valve. The anterior margin of the Ahmed valve should be 8 millimeter behind the limbus. Priming is a very important factor. We have to think, we have to examine whether the tube is patent or not. The valvular action is okay or not. Different challenges can be occurred here. In case of childhood glaucoma, when the tube, when the valve is going to be fixed, the sclera can be perforated as the sclera is very much thin here. The cutting of the tube is very much important. It must not be too long, whether it will touch the cornea or in the iris, and should not be too short, whether it can be come out. The tube entrance and entry of the tube is also a challenge where the decimate detachment can be occurred. Tube can be goes towards the pars plana route. Tube fixation is important, it's a challenge. I used to use the nylon to fix the tube. tube area should be covered with a graft. We can use the self-scleral graft. We can use the scleral patch, dried scleral patch, or we can use the tutoplast, dried pericardium. Here I have used the tutoplast. To me, it works better. After covering up the tube, it is very much important to cover the whole thing because the huge area of the conjunctiva has been excised, so perfect covering is very much important. It may cause leaking later on. This is another case where actually we have covered the whole thing with the patient's own sclera. So sometimes where the tutoplast or scleral patch is not available, can be possible to cover the tube with the self-sclera. Adi implant. This is a non-valved implant. You can see the procedure here with an animation. The importance is where we have to place underneath the muscle to fix the implant. Here are a lot of challenges we have to face, like muscle injury can be occurred, the surface area is more, so we have to make an extra large pocket for the implant, to implant the Adi. Here is the tube fixation. And the most important thing, as it is non-valved, so we have to just occlude the tube with suture. It is very much important. Tube entrance in the anterior chamber like Ahmed valve. Covering as usual. And there are some pores, there are some pores in the Barvelt and Adi implant, and there are fibrous capsule can grow through the through these small small perforations, and it creates a capsule. This is a case of a Barvelt implantation in a case of neovascular glaucoma. The procedure is almost same. We have to take the pocket, and also the muscle can be injured. Muscle can be injured in such Barvelt implant procedure. Can I take 2 more minutes? Just 1 minute, okay. Muscle can be injured when we fix the Barvelt or Adi implant. So we have to take care of that. So sometimes the Barvelt implant is very much expensive. It may not be available in each and every parts of the in the world. But to me, the covering of the tube is very much important. I have already explained the tutoplast is very much favorite for me. So preliminary comparison between the Aravind Oro lab drainage implant with the Barvelt glaucoma implant. It's a very good news for us that there is no, actually, Barvelt implant is very expensive, which is very much common in the Western countries, but Aravind aqueous device implant is a very good news for us. The output, same the postoperative visual outcome and everything, field and any complications, the same rate. So it is a good news. The Adi implant we can use on behalf of, we can avoid the Barvelt as it is very much expensive. But challenges, in case of advanced glaucoma, as the Barveld and Adi implant, we just occlude the tube. So in that case, where the glaucoma is very much advanced and where the raised intraocular pressure, what to do? That's really very challenging. In that case, I don't give the Barveld or Adi. I used to implant Ahmed valve, because in the Ahmed valve, it's a valve procedure is there, valve system is there, the tube should not be occluded. Muscle injury is a challenge in case of Adi or Barveld implant. Sometimes as the surface area is more, lot of sutures we have to give, so discomfort is a factor. And one and only, ultimately the complications is a great factor.
Please conclude.
So it is a case of just a counting finger. The patient has a counting finger, and the postoperative vision is 6:36 after. Thank you so much. Thank you for your patient hearing.
Thank you, Dr. Norman, for this very interesting presentation. Next, any question from the audience?
My question is, while monitoring patient of glaucoma with perimetry, the biggest challenge that we face in practice is high fixation losses by the patients. Many times because patients are old or not so intelligent or from low socioeconomic class, they keep on giving high fixation losses, and so the perimetry follow-up becomes unreliable. So what are your tips to reduce fixation losses from the patient's side?
Dr. Bass.
Yeah, it is really very true, because they have a very small island of vision left, and because of putting multiple anti-glaucoma drugs, they have a tendency of developing the dry eye as well. So the most important tip is that give a break in between the test, maybe after every 30 seconds or 1 minute, give a break, and keep on putting lubricating drops in between the test. So they would be able to perform much, much, much better.
Thank you very much. My question is, or clarification, is on the selective laser trabeculoplasty. The chair of this session did mention that it's not effective in Indians. I wonder why. Are there studies that had been done? Because 2 different studies have proven that SLT is actually very useful. If we know about the Rialini study in the Caribbeans, these are black eyes, brown, dark brown, and then the UK study has also proven that SLT, I mean, these are Caucasian eyes. So I wonder why that is so in Indians. Is there any study? Are there evidence to show that SLT is ineffective in Indian eyes? Thank you.
Dr. Deepak?
See, the SLT, what our experience is that in Indian eyes is more unpredictable as compared to the Caucasian eyes. We found that it is efficacious in around 70% of the eyes, and it's not only the efficacy, it's the amount of efficacy as well. In majority of the patients, it's able to reduce the intraocular pressure by around 15 to 20%. That is problem number 2. And you don't know in which patient it will be more efficacious and which patient will be less efficacious. And number 3, you don't know that how long it would last. You know, in some patients, the IOP lowering remains for 6 months. In some patients, it remains for 2 years. So these are the 3 challenges. That's why it has not become so popular as in the Caucasian eyes.
See, can I just reply to the question? SLT, in fact, when it started in India, we did a lot of SLTs, more than 250 cases in a very short span of time. And when I analyzed, we see that the results are temporary, and 2-3 months' time it comes back. The failure rate is quite high. To see why it is happening in Indian eyes, is it a racial variation or there is something wrong in our procedure? I visited 3 centers in Australia who do it very often and very repeatedly, and I realized their results are almost the same. The only thing, because the insurance is paying for the procedure. They are doing it 4 or 5 times in every case. So I was not very impressed of the results, and we feel that the racial variation is playing a role. I can tell you another thing, that there was the SLT International Forum in which I used to attend it very often. Many other countries like UK, as Madam said, UK, they shows a very good result, maybe possible, we don't doubt their as a credential, but other countries also agree with us. African countries also agree with their results are still poorer. So I think it's a racial variation which is a matter of concern, and we may have to change technique in some form or go ahead with the modified form of SLT, which might work for a longer time.
So that
Okay,
time
we have to
This is the last question,
This is the
yes.
last question, okay, madam?
so that time you said that perimetry is the only way we can monitor advanced glaucoma, right? But most of these patients who have advanced glaucoma, they are old. I've seen that they're old and debilitated, either having a history of CVA or senile dementia, Alzheimer's, hearing disabilities. So please, would you tell how to go about it, like for these patients?
There is no other way to monitor very advanced glaucoma except the perimetry. Somehow, you have to teach the patients to do it, and you have to spend lots of time to carry out the perimetry.
Patience is needed.
I think the perimetry in advanced glaucoma is a test of patience for the perimetrist, one thing. Second is that the 10-2 in the central area with 5 size of the target takes much less time, and it may have to be repeated. The patients have to be really, that's why I said it is a test of patience. So the patient has to be explained again, repeat for a good test, for a reliable test. Second is the total quadrant total is more important, and central few points around the fixation point we are concentrating on. That we are matching with the mean deviation. That is the only indication we have with the field of vision, field test, and there is only few points around the fixation point, and in the change in the decibel, and the quadrant value, total value of the 4 quadrants, that is important for us. We are not concentrating on the black area which is progressing from this side. It's not important.
Okay, we are concluding the session. Thank you everyone, all the panelists and all the audience for having patience here, and thank you all. Any other doubt we can clear, Anta?